Hello, friends in the NECADE village. I'd like to talk a little bit this afternoon about a topic that is becoming more and more relevant in the world of dentistry, and that has to do with dental sleep medicine. The title of our lecture, Implementing Oral Sleep Appliances into Your Dental Practice and Why It Matters. We're going to talk a lot about the 10,000-foot view here. There's lots of different organizations, continuums, seminars, lectures that you can take that will talk about the more granular information. My hope today is to introduce a lot of the concepts, but also provide you some guidance on whether or not to enter this world and whether or not it's right for you in your practice. So some objectives I'd like to do today. I'd like to dovetail the presentation that was given through the Region 1 AGD, which this lecture is dovetailing with. That lecture was provided by Dr. John Commissy, and he talked a lot about airway and sleep, where he introduced a lot of the concepts and also brought a lot of awareness to the world of dental sleep medicine for the people listening. I hope to build upon that particular lecture. Also, I'd like to provide some information whether or not this is right for you in your practice. Although I firmly believe that patients within every dental practice can benefit from this, your practice might not be the best. With that said, there's definitely some understanding that each of us can glean in order to help our patients make sure that their particular needs are met. Also, we want to provide some actionable flowcharts, checklists, and protocols for you in your practice. I don't know about you, but I've been to many weekend seminars where I acquired information, I watched a speaker show wonderful cases, improve qualities of life, and I thought on Monday morning I was going to implement all of that information immediately. We know that's very unlikely to happen first thing Monday morning. It's difficult to take all of that information and employ it into a very busy dental practice, which most of us here are generalists. I think we can all relate to. With that said, my goal today is to provide actionable information for you so that you can implement this on Monday morning, or at least that's our attempt. Specifically, I want to dive into one solution that dentists can use in the arena of dental sleep medicine, specifically the mandibular advancement device. This is the tool that I think you can use, every general dentist can use to help their patients. Throughout the lecture, I'm going to be talking about something called the Miro board. What I'm going to do is go ahead and zoom out, and I'm going to bring you over to a product called Miro. Miro.com is where you can go to learn more about this. What this is, it's a tool that I use both personally and within my practice to brainstorm, to create algorithms, flowcharts, procedures. It's just a very powerful tool if your brain thinks this way. My goal here is not to sell Miro, it's just to tell you that you'll have access to all of this information throughout the next several weeks as we keep this particular link live. I'm going to spend time zooming in on several areas, so if you can't see this right now, that's okay. But the center here starts with, I want to help my patients live a higher quality of life. Well, if that's you, you've come to the right place. This lecture is going to talk a lot about that. But what I want to do is provide this Miro board so that you can access all of the documents that dovetail with the PowerPoint presentation. We only have an hour here today. There's no way I'm going to go over all of the documents that we've come up with that can help in the world of dental sleep medicine. But if you come here, you can access them, peruse them as you like, employ them as you wish. These will be available to you anywhere around the world if you have access to the internet. If you see a topic that has an underline and has this blue color to it, there's a link associated with it. You just click on it, and then there'll be a Google document. So we use Google Docs. You may have to sign up for Google Docs in order to access these. You can convert them to Word, Excel, PowerPoint, all of the tools that you're likely to be familiar with Microsoft. Once you're done there, you can come back to the Miro board and continue perusing. Again, I'm going to come back to this at several points. When you hear the term Miro board, this is what I'm referring to. Okay. So let's go back to the slideshow. and talk a little bit more about Dr. Kamissi's presentation a year ago. Very similar to many presentations on the world of dental sleep medicine. But today I wanted to provide a little bit of the highlights that he had presented in his lecture. First and foremost, he's been doing this for a long time, so when he says this, I do believe him, and I also live this world too, so I believe the experiences that I've been fortunate enough to be part of. Oral appliance therapy works. There's no question in the world of dental sleep medicine, this stuff is changing lives every day. There was definitely a period of time when the world out there thought that this particular world didn't have any application. It definitely works. We're going to talk more about that as time moves on. He talked a lot about the importance of sleep, both quantity and quality of sleep. There are very few things in our life that are going to have the impact on our quality of life like sleep. He also talked about polysomnograms or sleep studies. These are the tools that sleep physicians use in order to gather data about the quality and quantity of somebody's sleep. He talked about tools such as the pharyngometer and the rhinometer. These are tools that dovetail with the polysomnograms in order to get as much information as we can to, one, properly diagnose and screen, but also treat, and then evaluate the treatment thereafter. We're going to talk more about this as time goes on, but I wanted to provide this in the context of his lecture because it's an article that he wrote in the Academy of General, or the Journal of General Dentistry in July and August of 2020. He talked about the vertical component mattering. What does that mean? Well, most oral appliances intend on improving the airway by moving the jaw forward. And we're going to talk a lot more about these specifics, but I just wanted to bring it up here. He made the very valid point that the vertical component also matters. We had found that anecdotally, but there's not a whole lot of scientific literature out there. This is really the first of its kind, and I hope that it's a launch pad for many more scientific endeavors to understand that it's not so much about how far to pull the jaw forward, it's actually pull the jaw forward a little bit and then open it a little bit. There's a sweet spot there. We're going to talk about that. He also introduced a pearl or a take-home message. Do not treat your patients for snoring alone. Always get them a sleep study. In other words, you shouldn't do any of this unless you have a prescription from a physician. The reason is lots of patients can have snoring or report that they snore, but without proper testing, that might actually be sleep apnea. If you make an appliance without fully knowing what the diagnosis is and you're not adequately treating them, you could be held liable. And I think that's where a lot of the fear comes from, is being held liable in this arena. I promise you that if you follow the protocols and the algorithms that we're providing today, you will be 100% practicing within your scope of practice in any state in the United States. How about some common myths associated with dental sleep medicine? Well, first and foremost, we hear this one all the time. I'm a dentist, I shouldn't do this stuff. Or, you're a dentist, you shouldn't be doing this stuff. I've definitely heard that term before. I would actually provide the counter argument. You're a dentist, you should be doing this stuff. And we're going to get into that more as the time goes forward. Another common myth, well, since I can't diagnose sleep apnea, I cannot treat it. This is 100% incorrect, but it definitely permeates through dentistry and is preventing a lot of patients from having their lives changed. To help articulate this a little bit, let's kind of move horizontally into a thought experiment. If you were a pharmacist, would you not provide medications because you did not diagnose the patient with the condition that the medication is treating? Pharmacists have no role in the world of diagnosis. They fill a prescription that is given by a doctor who came up with the diagnosis and provided the prescription. That same workflow applies here in dental sleep medicine. We as dentists are screening sometimes. We're not diagnosing. The sleep physician or the primary care physician is doing that, or the ENT. Those individuals with the scope of practice to provide the diagnosis and the prescription will then give us the green light to go ahead and create the appliance. At no point along the way as a dentist, am I providing a diagnosis for obstructive sleep apnea? Therefore, you 100% can do this, just like a pharmacist can fill a medication. What about this one? CPAPs are the only acceptable treatment in the treatment of OSA, or obstructive sleep apnea. Well, that is incorrect, as we're going to see. And not only is this incorrect, but lots of patients don't wear their CPAPs, as we will soon find out. Therefore, we have to have other forms of therapy. And it just happens to be that we as dentists can provide that for them. Is our CPAP still the gold standard? Yes. Are tools that we can provide as dentists still acceptable? Yes. Is it very likely that someday the appliances that we make as dentists will also become gold standards? Yes. As we will see, that is going to be the case. Another common myth, although not necessarily related to the topic of today's presentation, is the concept of home sleep studies, or HSTs. There is quite a bit of misinformation out there that these don't work. These 100% provide insight. They provide screening tools. They provide awareness and understanding for our patients. They play a very critical role in the world of sleep medicine, not just dental sleep medicine, but sleep medicine. So if you hear this rumor, run the other way. Now, this one is probably the most relevant one to general dentists. We hear this all the time. I don't do those appliances because they make people's bites go in the wrong direction, or it ruins their bites. Let's do another thought experiment. So let's move to the side. Answer the following question. What's worse? Having an imperfect bite or being dead? I'm sensationalizing this a little bit, but not really. In reality, we know untreated sleep apnea is likely to cause death far more than any sort of quality of life change that might arise from a changed bite. Not only is that true, but in reality, there's ways for us to prevent this from happening. There's ways to us to address it if it does happen. And most importantly, if we know that this is true, we can educate our patients and set the expectations accordingly so that they understand that this might just be a side effect of a treatment that you absolutely need. At the end of the day, how many medications and medical treatments out there come with zero side effects? If we think of it that way, it really puts it in perspective that this kind of treatment absolutely has its place despite the fact that we might be changing the patient's bite. Emphasis on the word might. As you start to introduce yourself to this world, I would strongly recommend finding yourself one of many different resources. Personally, I would start with these 5 books. Yes, they all are somewhat redundant, but they all come at it from a slightly different angle, and I think there's a lot of value, not only for yourself, but also your patients. These books are not written for the dental professional. They're written for the dental professional, his and her team, staff, and patients. In other words, the layman. If you're going to pick one, don't pick them all. I can promise you that if you read these books, you're going to have a completely different aspect of your own personal life, but also how you treat your patients. If you read these books, you will be practicing dental sleep medicine, I promise. There's no way you could read these books and then unsee what you're going to see in these books. If you're going to start with one, start with the one not written by a dentist. The book, Breathe by James Nestor, is probably the best when it comes to connecting the dots, not only from the world of dental sleep medicine, but just breathing in general, and then kind of find your way around the other books here. There's many more. Start here, keep reading, keep learning. Your patients will benefit immensely, I promise you. All right, so enough with the introduction. As with all topics, I like to start from the 10,000-foot view. In this particular image, we're going to talk a little bit about how does this relate to dentistry. Sleep disorder breathing, the acronym SDB, deals with the world of breathing that is inadequate that results in some sort of systemic problem. There's a disorder in the breathing, and it's typically associated with sleep, as we will see. But let's look at the sagittal view here and just do a little bit of orientation. Here we have the nose, the nasal cavity. We have the hard palate, or the roof of the mouth, the soft palate and the uvula. Here's the oral cavity, the tongue. Here's the lips, staying closed. We don't want this particular compartment open, as we will learn more about shortly. And then here we have the pharyngeal tube, or the oropharynx and the hypopharynx. Okay, so it's very important that we come back to this and we think about how we're playing a role in the world of dental sleep medicine. As we work on the teeth, we are 100% affecting this part of the body. At the end of the day, it's not that far away. To give a little bit of nomenclature so that as we use these terms, everybody knows what we're talking about. Our pharynx is made up of, essentially, it's the air tube, or the tube at which the air flows in our body, starting with the nasal valve, or the external nasal valve, and ending with the trachea into the lungs. It's this area, this real estate, that we have a lot of responsibility for. As we can see, the teeth are right nearby. We are responsible for this tube. So the nasopharynx essentially is the superior part of the pharyngeal space. The oropharynx, that's the term we're going to use the most, because this is the area that is most likely to cause problems, but it's also the area that we have the most control over. And then the hypopharynx into the trachea and the lungs. Well, sleep disordered breathing is the overriding term used to describe several conditions. When you enter this world, we often think of sleep apnea or obstructive sleep apnea, but in reality, there's a whole host of conditions that fall under this umbrella. The first, which is unrelated to our world, is central sleep apnea. This is not something that we're going to get involved with. This is for the sleep physician or the neurologist only. I like to think of central sleep apnea as an electrical problem. The electrical information to the body to provide quality and good quantity of sleep has some issues. This is not something we're going to see, or not something we're going to treat. Contrary to that, obstructive sleep apnea, which is a separate diagnosis from central sleep apnea, is something we're going to see a lot of and treat. There's another condition called upper airway resistance syndrome. That's what I call the cousin condition to OSA. It's also fairly unknown in the world of dental sleep medicine. It's becoming more and more relevant. We're going to talk a lot about this because I think you can help your patients improve their quality of life tomorrow that come with this condition, which is very prevalent. And then we have snoring. Now, snoring, we could think of as the predecessor to obstructive sleep apnea. It is a condition, it is a diagnosis in the world of medicine, but we can also think of it as a sign or a symptom. And as we will see, that's very important for us to understand. Just so we can help segment these particular conditions as they associate with the anatomy of the sagittal image here, where is it that these problems arise? Well, if you have obstruction somewhere in your in your airway, you will have a problem. Well, as the term upper airway resistance syndrome implies, if we have a blockage in this particular part of the airway, this is a condition that we can have. This is not the topic of today's conversation, but as you start to learn more and more about how you can help patients with obstructive sleep apnea, you're going to start to realize that a lot of these patients also have some degree of this condition. And then you'll also start to learn how you can identify patients within your practice that have this condition so that you can help them. Remember, we see our patients way more than our primary care physician colleagues do. If we can understand what to look for, we can help patients. I promise you, if you understand UARS, you're going to help lots of people. Not by diagnosing, but by screening, and to some degree maybe treating. But most importantly, quarterbacking the patient to the right provider so that that provider can provide the treatment necessary. But more relevant to today's conversation are these two terms, snoring and obstructive sleep apnea. For the purposes of today's presentation, we can think of snoring as the predecessor to mild, moderate, and severe sleep apnea. They arise from more or less the same area of the head and neck. There's lots of variations to this topic. Again, today is not to talk about the specifics, but to introduce the concepts so that you can understand how they play a role in your patient's practice. Snoring and sleep apnea come from the oropharynx specifically, most of the time coming from the tissue of the tongue, of the posterior part of the tongue, and the posterior wall of the oropharynx, or the pharyngeal space. It's the slapping of these tissues that creates the snoring sound, and if severe enough, causes obstruction of the airway. So when you think of sleep apnea, remember this little area right here. Well, here's another diagram to show proper airway, breathing through the nose, and then a patent airway so that the air can flow all throughout the airway into the lungs. Well, as you can see with this dotted line, there's not a whole lot of space there. It's very easy for this to collapse, as we can see here. As we fall asleep, gravity takes over as we lie on our back, and relaxation of the muscles in the pharyngeal walls increases the likelihood that we're going to have a more flaccid nature to those tissues. It's not a secret that if you have alcohol before you go to bed, you're more likely to snore. Why is that? Well, it's because the muscles within this area are more likely to relax. Not saying that's right or wrong, just providing some context for everybody out there that this kind of stuff lives in everybody. Well, how can we help? So this is the introduction of how we enter this world of dental sleep medicine or sleep medicine to help. The tongue, let's come over to this particular slide here. The tongue is attached to the mandible. That's a good thing because if we move the mandible forward, we can move the tongue forward, thereby reestablishing in patients who have collapsed airways a patent airway. That is what we call oral appliance therapy. Again, there's different ways to do this. The mandibular advancement device is one. We're going to focus our efforts today on that, but that's the take-home message. But before we look at that, let's go back to one of those myths. I'm a dentist, I shouldn't be doing this. Well, let's just look at the workflow to hopefully decrease the fears associated with this form of treatment, but also to provide some value in how you're going to work very closely with your medical colleagues to help these patients, okay? So here we have a patient with sleep disordered breathing. They may know it or they may not. If they don't know it, we can elucidate that through screening and referral, and we can do that as dentists, hygienists, the primary care physicians, and the ENTs can all screen their patients for obstructive sleep apnea and UARS and refer to the sleep physician. We all play a role in this. Now the patient is aware and they're seeking evaluation from the sleep physician. Okay, that's the first step. We played a role in it. We didn't do anything outside our scope of practice. Well, let's just say that there's no diagnosis. Well, for most of these patients, if they don't have a diagnosis, what they do have now is awareness. And I'm a firm believer that patients who are aware are more likely to realize that if they enter the world of becoming apneic through obstructive sleep apnea, that they're going to know to ask the questions to their primary care physician or their dentist when the time comes. So these patients that are at higher risk that don't have a diagnosis are not immune for the rest of their life. They're just not currently under that state of diagnosis. But because of the risk factors and the signs and symptoms that led you to think they might have it, they're at higher risk for developing it at some point in their life. So a no diagnosis situation is still a good situation. So that patient then becomes diagnosed. So aside from the patient without the diagnosis, let's just say that the patient becomes diagnosed with sleep disorder breathing, which under that umbrella comes OSA and UARS, or snoring. Again, snoring is a diagnosis. If that patient has been diagnosed, their sleep physician may decide to prescribe a Cpap. That's the most common workflow that we will see in medicine today. Again, the Cpap is still the standard of care. I'm not here to say Cpaps are bad. I'm just here to say there's other ways to treat the patients. Well, if you have a well-educated sleep doctor, they may prescribe an oral appliance. Much of the time that comes from education from us as the dentists. I have run into several sleep physicians that really just think these things don't work until they get a patient that you did treat, and that patient says, I'm so glad I saw Dr. So-and-so. I hated my Cpap, and thank you for providing that information. They're speaking to the sleep physician. The sleep physician says, okay, well, maybe there's something to this. And then the second patient shows up at their doorstep. After about patient 4 or 5, the sleep physician is then referring you patients to treat for obstructive sleep apnea. Now, they're not sending you all their patients, they're sending you some patients. And educating the sleep physician so that they can understand who these patients are is a very important part of this overall algorithm. Now, what about the patients that were prescribed the Cpap and become what is termed intolerant? These are the most commonly helped patients in the world of sleep disorder breathing. You have patients in your practice right now who are prescribed Cpaps that don't wear them. If you have more than 10 patients, I guarantee you have at least one. I would hope everybody here has more than 10 patients. Therefore, there is somebody you can help within your practice that falls under this category. They have a Cpap, they don't want to wear it, or they hate it. These are the people we can help immediately. Very easy, low-hanging fruit. And we're going to talk about workflows to help you work with your sleep physician so that you can start treating your patients tomorrow morning. Then you fabricate the appliance. And we're going to talk about how to do this today. There's lots of different ways to do it, but I want to spend more time in helping you understand this world is absolutely right for you, your practice, and your patients. Well, maybe you don't believe me. Well, the ADA has produced a position statement back in 2019 that more or less employs the absolute necessity for you to at least screen your patients for this. I've had several conversations with doctors from similar lectures that give me the following statement. Well, on my medical history form, I asked a patient if they have sleep apnea. Okay, that's not the point here. Asking a patient if they have sleep apnea is great, but we need to be screening for the patients that don't have it. So what is on the medical history form that will provide clues for you to dig deeper to help the patient understand whether they may or may not have this condition? On the Miro board, I have this particular position statement. If you're going to get into this world, which I can't see any reason you won't, 100% take advantage of reading this document. It's only a page and a third. Please read this. You will feel much more comfortable in this world after you read the position statement from the ADA. Keep in mind, the ADA is not a governing body of our profession. You don't have to do something because the ADA says it. But your state dental boards glean a lot of their guidance from the ADA, and you absolutely have to follow your state dental board. So don't be misled to think that the ADA doesn't have a role in your particular practice. Please read this. I promise your state dental board has a copy of this themselves. What are the highlights from this particular position statement? Well, first and foremost, dentists are encouraged to screen patients for sleep disorder breathing as part of a comprehensive medical and dental history. Yeah, everybody does this. No, unless you know the stop bang protocol, the Epworth sleep study test, and all of the clinical signs and symptoms of sleep disordered breathing, you're not doing this. We have this in the Miro chart. All of the documents I just spoke about are in that flow chart. Please become familiar with these so you can help your patients live a better quality of life. Another highlight from the ADA position statement, oral appliance therapy is an appropriate treatment for mild and moderate sleep apnea and for severe sleep apnea when a Cpap is not tolerated by the patient. What they're saying here is you can absolutely do these for patients with a prescription from a physician in place of a Cpap if the condition is mild or moderate, which is going to be most of your patients. Most of your patients are not going to be in the severe range. With that said, most of the patients you're going to help, the lowest hanging fruit, are the patients who have severe sleep apnea that are intolerant to the Cpap. And here's the position statement from the ADA, giving you the confidence that you can absolutely do this with the comfort of knowing you're practicing within the scope of your dental license. This is probably the most important one. Dentists are the only healthcare providers with the knowledge and expertise to provide OAT, or oral appliance therapy. I don't know if you've been to your physician's office recently, but tell me if you've seen any bite registration or PVS impression material, an iTero scanner in their office. I say this a little tongue-in-cheek, but the reality is physicians don't have the technology or the know-how to make appliances. Well, hopefully I've made the case that appliances are 100% part of the workflow in successful treatment of sleep disorder breathing within medicine. Well, dentists have to be part of this. And if you're not providing this for your patients, you better know somebody who does, because it is your responsibility to make sure these patients are getting the care. Pretending this stuff doesn't work or pretending that you're not capable of doing it does not absolve you from the fact that you're still responsible for helping these patients. Well, we started at the 10,000 foot view, and I just want to quickly maybe take a step back to the 20,000 foot view. I think it's very important that we understand that these patients that we're treating for sleep disorder breathing ended up there somehow. Maybe this isn't the topic of the conversation today, but I absolutely wanted to bring it up, to bring it into context so that you understand there is so much we can do to help all of our patients in the world of breathing. So if we break this particular diagram down, the vertical axis is increasing patient age going down. We have three different arenas: the treatment mode, treatment types, and specific resources. The treatment mode for our young patients, let's just say somewhere between the age of newborn to 10 years old, we can prevent not only the problems from arising and being relevant at that age, but also manifesting and showing up later in life. Yes, we can make mandibular advancement devices. But if we ask ourselves the question, how did that patient get there in the first place? Then you might ask yourself, well, how can we prevent them from getting there? We can't go back in time with the patients that we currently see in the adult mode, but we can absolutely help the patients that are younger. Different ways of doing this: phase 1 orthodontics, myofunctional therapy, having kids chew hard foods to stimulate craniofacial growth, nasal breathing. As you can see, I'm wearing a Breathe Right strip. I'm a huge proponent of nasal breathing, and art tools. And there's different ways to get resources to all of this. Having a great orthodontist that's airway driven is an absolutely critical part to this. An airway driven ENT, they're hard to find, but they're out there. Myofunctional therapy training through the AHS, drawing a blank on who that is, Airway Health Solutions, organization that will help you with myofunctional training, and then the books we talked about earlier. Well, maybe you have a patient that's 11, 12 years old. They've missed the point where we can really positively impact skeletal growth. Unfortunately, the teeth are now crowded, and now we just have to do a dental solution rather than a skeletal solution that we see in the prevention modalities. Well, phase 2 orthodontics, we can do palate expansion, surgery, myofunctional therapy, and nasal breathing. Again, there's lots of resources out there for that. Well, the patients made it their way to adulthood. Unfortunately, they now have an incompetent airway. Well, that's where we come in as general dentists. We can do things like surgical palate expansion. We can use removable palate expanders. Topic for a whole nother conversation I would love to share with somebody at some point in time. Maybe visit our NECADE YouTube channel. We talk a lot about you can expand palates in adults very safely with removable palate expanders, but I digress. Aggressive orthodontics, we know that moving teeth in adults has more chance for fallout and side effects. Sleep apnea therapies, that's the focus of today's conversation, and then there's lots of resources that we can go and find help in this arena. We're going to talk a lot more about those as we move forward. In this continuum, here's where our focus is today: oral appliances, or specifically the mandibular advancement device. But please understand that you're helping a patient that could have been helped decades ago. So you might ask, well, this sounds great, but where the heck do I start? Well, my goal, hopefully, is to provide some insight with this. There are two very specific ways I recommend entering this world to people who ask, how do we do what we do? I didn't have this clarity when I first entered this world, but here's my attempt at hopefully guiding you into making the right decision on how to enter the world of dental sleep medicine. There's the all-in approach, where you sell your practice and you open up a dental sleep medicine practice, or something to that effect. Or the basic approach, which is what I'm hoping most of you do starting tomorrow, in that you're treating your existing patients and hopefully giving them a better quality of life. Well, let's take a look at the all-in approach. Again, this is in the Miro board, replete with all kinds of resources and tools, so that if you decide to do this, you'll know how to do it. Well, the first kind of dentist to do this is what I call the tired dentist. That's the dentist maybe that's near retirement, tired of doing class 2 composites all day. Maybe they're just kind of sick of having a large practice and they just want to do something different. Or a dentist who just realized practicing with their hands is not their cup of tea. That might fall into that category. Another kind of dentist that might take this approach is what I call the medical dentist. This is the dentist that loves the idea of working with their medical colleagues very closely on a day-to-day basis. They may feel like they're closer to improving the quality of lives of their patients because they're closer to medicine. However they rationalize it, there are a subset of patients that are doctors, dentists that go in to dental sleep medicine that take this approach. The large dental practice, that's a little bit of what we do. We're definitely in the all-in approach, but we're able to do it because we have a lot of resources within our practice to offer these to patients while also being very efficient and effective at it. So there's all kinds of different ways to consider going into the all-in approach, and please consult with the Miro board if you want to do this. My goal today is hopefully to tell you not to do that. The everyday GP can't do this. If you're a solo doc practitioner or you're part of a smaller group practice, you have way too much to do in the world of restorative dentistry to add this to your plate. As you start to unravel the onion in the world of dental sleep medicine, although very exciting, it starts to consume you and take a lot of your time. If you do this intentionally, you're going to absolutely love what you do. But if you try to do this on top of your already growing list of responsibilities as a business owner, as an associate, as a husband or wife, and a parent, this can become very overwhelming. And I've seen many dentists that go down this road, spend lots of money on education only to find out this is really hard to integrate into an already busy dental practice. With that said, we have a different way of doing this. We call it the easy button, or more appropriately, the easier button. There is no easy button in dentistry or medicine, but hopefully we can provide an easier way for you to immerse this into your practice, test out the waters, help people live a better quality of life, and if you like it, then you can maybe consider the all-in approach. We call this the basic approach, and this is definitely for the everyday GP, which is myself and the audience we have here. This is a screenshot of the Miro board. I just wanted to kind of quickly go over that there is an algorithm that helps you decide how to help your patients. Why don't we zoom out and go over to the Miro board. All right, in the center here we have, I want to help my patients live a higher quality of life. You'll have access to the PowerPoint presentation here. if you want to go back and watch that. I will also include a link to the video somewhere over here so that you can watch this video. We have all kinds of resources here. The ADA policy statement I talked about earlier, common myths about oral appliance therapy. How do I get started in the world of dental sleep medicine? This is a great place to start. All kinds of resources there. Then we have the basic approach, the all-in approach, and something I call the moderate approach, which we're going to spend a little bit of time talking about. Why don't we quickly go in and look at the all-in approach? As you can see in the parentheticals I put, to do this, you really need a lot of patience. Now, most people that go into this think that just by becoming a dental sleep medicine dentist, that patients are going to come out of the woodwork. There is a great degree of networking and value building that you need to do in order to get patients to come to your practice to receive this care. Let's just say you find yourself there, then you can initiate what we call the education process. The American Academy of Dental Sleep Medicine Mastery Series is by far one of the highest quality dental CE things I've ever taken. As a master in the Academy of General Dentistry and having amassed over 1,600 CE hours, I definitely think that this is worth your time doing. They did a fabulous job of it. Again, worth its weight in gold. After the Mastery Series, you can then take your diplomat in the you can sit for your certificate or your diplomacy in the American Board of Dental Sleep Medicine. There are very few things that you can achieve in this world that have higher stature. Once you do that, you can do things like open your own dental sleep medicine center. Although you don't need this to do that, I wouldn't create such a center unless I had this title after my name. If you find interest in this world and you want to expand your horizons, I recommend taking Dr. Stephen Almos's curriculum. Click on this link and it'll take you to his website. What he does is he dovetails TMD with sleep. He did a fabulous job of diving into the literature and elucidating the connection between TMD and sleep to help us understand those two things are very much one and the same, and they're very much treated the same. Once you get into this world, you'll get a better sense of how you can help your patients not only with sleep, but with TMD. After that, you can open a sleep and TMD center. This isn't for everybody, but if you decide to take this approach, there's one way to do it. We also have the moderate approach. If you find yourself doing 3 to 15 cases per month, then I would consider looking at sleep group solutions. They have seminars all over the country. Although I love sleep group solutions and I've paid them a lot of money to help implement the dental sleep medicine practice within my practice, I don't think this is the place to start. They will absolutely help you start if you've got the money to spend. The problem is if you don't have the patience to support the investment, then it's all for nothing. I really recommend taking the basic approach, prove that you like this world, prove the concepts, make sure that you love this arena. Then, once you're seeing about 3 cases a month, then you can consider the investment with sleep group solutions. Thereafter, if you start to do more and more cases, then you can find yourself over to the all-in approach and take the education curriculum as we talked about earlier. But I'm assuming everybody's here to learn more about this world. I'm guessing that most people here have never heard of any of those and probably have not done any cases. If you have, hopefully I'm providing a different perspective on this world. But in the world of the basic approach, less than 3 cases per month, which is where you're going to start, we have this algorithm or flow chart here. Again, you're going to have access to this. Well, what's the first thing you need to do? You need to identify a patient. Either that comes from reading something on a medical history, something they said, maybe you have an advertisement of dental sleep medicine in your practice and they asked about it. There's all kinds of different ways to increase awareness for your patients. But let's just say you now have a patient in your chair that has been identified as being likely for having sleep apnea. Or they have sleep apnea and they don't wear their Cpap. So those are the 2 major avenues. So the first avenue is this one here. We talked about the low-hanging fruit. It's the Cpap non-compliant patient. These are the patients who already have a diagnosis. All of the hard work's been done by the sleep physician. They've had the polysomnogram, the sleep study, and all of the things necessary to come up with a diagnosis. They then wore the Cpap, and they decided they didn't like it. You would think that with the improvement of patients' health, that everybody would wear them. Well, we know that this isn't the case. I don't have the exact statistics offhand, but I can tell you that at 5 years, the compliance rate is somewhere around 50%, plus or minus 10-15%. The point is, there's lots of people out there that are like this. We call them the intolerant Cpap patients. Well, those are the patients you can help immediately. So you have two options from this point. You can go this way or you can go this way. The first is you have somebody within your network of colleagues that provide this care. You have a dental sleep medicine expert within your community, and you refer that patient to them. You are 100% helping them. You are also not giving your patient to another dentist. I can almost promise you that most dentists that do this is all they do. They're not looking for your class 2 composite cases. They're looking to help this patient and then send them back to you. To help align the expectations, I do recommend sending this letter. It does talk about the fact that you want your patient back, you want to continue restorative and preventative care. You just want that dentist to treat the patient just like you would if you send a patient for a root canal. Your patient still come back to see you, their general dentist. Well, part of this is really important because we need the patient to understand, essentially we need the patient to understand what's going on. So we have what are called pie sheets, or patient information essays. This is an acronym that we came up with. We give these to patients when we need them to understand things much more than the 20% of the information they remember when we tell them verbally. We all know, we sit down with a patient, we spend 10 minutes with them, we see them 2 weeks later, and we bang our head against the wall because they only remembered a little bit about what we said. Well, pie sheets are great for that. They're essentially just documents in some form or another to give your patients to help them understand what's going on. We have a pie sheet for this particular interaction, referring a Cpap non-compliant patient to a dental sleep medicine dentist. But you're probably here because you want to learn how to do this stuff yourself. So let's just say you make the decision. We're going to go over how to do it, but let's just say you make the decision to do the case in-house. Well, what did we say earlier? All of these patients, we want to have a prescription from the sleep physician or the primary care physician. Here's a letter. If you click on this, again, the mirror board has live links. You can click on this, and what will come up is a letter to the primary care physician. Let's just go ahead and take a look at it. So NECADE, template letter A, letter to the primary care physician for the Cpap intolerant patient. You can download this and change it at your will. Basically what this is saying to the sleep physician is the patient has been diagnosed, they're intolerant to the Cpap. Oh, by the way, there's all of these things that we can use called mandibular advancement devices or oral appliances. If you don't believe me, here are some resources. So a bunch of resources for your primary care docs to learn more about this world, and then directions to provide a prescription for you. So you send this to the primary care physician or the sleep physician, and then hopefully you get back a prescription to fill it. All right, so hopefully you end up here. Prescription obtained from the primary care physician. Later in this lecture, we're going to talk about what to do from that point forward. But let's just pause at this particular point of the workflow right here and go back here. Let's say the patient hasn't been diagnosed, and based on your growing body of experience, you think the patient might have obstructive sleep apnea or upper airway resistance syndrome or some form of sleep disordered breathing. Again, there's screening tools available to you right here. Maybe we should have put that higher up on this workflow, but let's just say you have a patient you think is at high risk. Well, the first thing you can do is send them to your friend across town who specializes in dental sleep medicine. There's a pie sheet for that patient. You don't need to necessarily know whether they have it. You're just trying to help the patient out, and you want them to get evaluated by somebody who's really good at evaluating them. That dental sleep medicine has a network of ENTs and sleep physicians to hopefully come up with a diagnosis and treatment. Again, the patient will return back to you. But let's say you want to do the screening and you want to do the case in-house. Well, you need to send a letter to your primary care physician. This letter is different than this letter. In this letter to your primary care physician or your sleep physician, it talks about asking them to look further and some supporting evidence on why you think they might have sleep apnea. That physician's responsibility is to then order a sleep study, get the patient evaluated, and then hopefully come up with a diagnosis and tell you, the dentist, what to do. Now, after this, they may decide to do a Cpap. That's fine. You help the patient live a higher quality of life. But hopefully, when you do enough of this with your primary care physicians, there'll be less and less of those cases ending up as Cpaps and more ending up as oral appliances. You then get that patient who then has a prescription for the oral appliance therapy, and then you move forward into, well, how do you do this in the first place? These 3 documents are topics that could be lectures in and of themselves. This one right here, initiate OAT treatment, is rather comprehensive, as you can see here. Unfortunately, it's not downloading. But what it does, it's a step-by-step algorithm for you to comfortably take advantage of the information that's on there to help your patient with a mandibular advancement device. I also recommend working with a lab. Here I put Diamond Orthotic Lab. I don't have any sort of financial interest with Diamond Orthotic Lab. I just know that they're a lab that knows how to treat these patients. If you send your appliance to Glidewell, you're going to get what you get. You're going to get what you pay for. Not that Diamond Orthotic Lab is expensive, but they understand. This is what they do. They make orthotics, and they specialize in the world of dental sleep medicine. In order to get there, we need a tool, and that tool I'm going to talk about today as we move forward is called the Phonetic Byte. I'm not here to say centric relation and neuromuscular positions are incorrect. I'm just here to tell you that if you want something easy, reproducible, and effective in the world of dental sleep medicine, start with the Phonetic Byte. And you might just continue using the Phonetic Byte for the rest of your career. So that's it in a nutshell. There is one other thing I want to talk about, establish dedicated team member. Go ahead and click on this document and read what we put there. The point is you want to have somebody on your team other than you who does a lot of the legwork. You don't want to train your entire practice on this. You want to train one person and have them be the point of contact moving forward, because it can be an overwhelming arena. You really need to have an extra set of hands on deck to help you with the various aspects of dental sleep medicine. So if we zoom out, the last bit here, I put these little pink tags here. Estimated time frame. What do I mean by that? Essentially, that's the amount of time that it's going to take for you to start employing this particular world of dental sleep medicine. Well, with the basic approach, you can start tomorrow, as long as you read the documents that are there. Or you can take the moderate approach, which might take you 1 to 2 years and anywhere from $40,000 to $50,000. Or you can do the all-in approach, which is maybe $40,000 to $50,000, maybe more, maybe less. There's different ways of going about this, but this is not your entry-level option. This might take you 3 to 7 years to get to this point. If you're out there and you see AADSM Mastery Series and you decide you want to start doing this, you're probably going to be underwhelmed. Please start with the basic approach first, get some reps under your belt before you go down either of these other 2 options. Well, we talked about the fact that there's different oral appliances. The arena, or the specific kind of appliance that we're going to talk about today, is the mandibular advancement device. When you think of oral appliances, many people think of these. They are not one and the same, but you can think of them as one and the same from the standpoint that you're more likely to use these than any other appliance that we can find. With that said, maybe for our edentulous patients, we might use something called tongue displacement. There's different tools and additional tools out there. And we can also improve nasal breathing, which can treat sleep apnea. Again, how do these appliances work? Well, we went over that. If you pull the mandible forward, you then, in the right patient, pull their tongue forward, and you can treat, to some degree, obstructive sleep apnea. Now, it's important to remember one thing. There's a concept called maximum medical improvement, or MMI. In the world of medicine, 50% improvement is good. In the world of dentistry, if our shade isn't perfect, if our marginal ridge isn't perfect, then we failed. In the world of medicine, perfection is very unlikely. Why is this important? Well, your patients aren't going to go from having sleep apnea to being healthy. They're going to have a continuum of treatment outcomes. So it's important to know that different appliances have different effects, and we have to understand how they work in order to understand how to improve these patients' quality of life. But how do we do this? So how do we go from, okay, we have a patient that has sleep apnea, and I want to improve their quality of life? Well, the first appointment that you're going to see the patient is what's called records. Pretty basic. All you're going to do is an upper or lower impression. You can do that with either PVS or your impression material of choice. Or many of us out there have digital scanning technology. We're going to capture the arches. Although a topic for a different conversation, if you're going to work with Diamond Orthotic Lab, make sure to capture the hamular notches. It's a very important anatomical landmark when it comes to a variety of different things in the world of dental sleep medicine and TMD. Just putting that out there. If you're going to work with them, ask them what a perfect scan is so that you know to capture the hamular notch. We're also going to do a bite registration. We talked about the phonetic bite. We're going to spend some more time talking about that later. There's a step-by-step protocol in the Miro board if you click on the word phonetic bite. And then you're going to ask Diamond Orthotic Lab for an ONP appliance. ONP stands for Almost. Dr. Almost is the originator of this particular appliance. And for nighttime, he has a daytime and a nighttime appliance. The daytime appliance is for our TMD patients. The nighttime appliance is for our TMD and airway patients. Again, TMD and airway are one and the same much of the time. And then the P stands for positioner. It's a mandibular advancement device at the end of the day. He just gives it a special term. It's a little more accurate in the fact that it's used at nighttime and it positions the mandible appropriately. As we talked about, there's different methods of capturing the bite. Now, earlier in the lecture, we talked about the more historical perspective of the fact that many dentists used to, and still do, advance the mandible forward in a protrusive bite, inject the material, send that to the lab, and that's where the appliance of choice is fabricated. Again, we're looking for a three-dimensional position of the mandible in relation to the maxilla. I'm going to say that again because that's what we're trying to do here. That's really what we're trying to do with all comprehensive dentistry. We're trying to find the perfect position for what we're trying to do of the mandible in relation to the maxilla. How do we do that? Well, in dental school, we were taught, let's put the patient in centric relation. Well, centric relation pushes the mandible, I don't want to say it, but posteriorly and superiorly, and that can close the airway. Now, proponents of centric relation might say if you do it right, then you actually open the airway. I'll let you figure that out on your own. I prefer a different method. Well, then there's something that came along in the mid-'80s called the George gauge. And the George gauge was simply a tool that allowed us to quantify how much protrusion we were actually giving. To use this tool, you have the patient slide as far forward as they can. I don't know if you've ever done it, but it's uncomfortable. My joints don't really care for it. Then you dial back about 40%. You find there's 60% of max protrusion, and that's your starting point. although there's some value into where they came up with that data, I would rather not do that. I don't want to overstress the TMJ. Much of the erroneous nature of changed bites as a result of mandibular advancement devices comes from this technique. We have a better way of doing it, and as you will see, you'll change less bites. Again, bite changes is not a bad thing when we're improving people's quality of lives and preventing them from dying. As Dr. Kamisi talked about, there's something called the pharyngometer. The pharyngometer is a tool that uses an acoustic signal to find the proper position of the mandible in relation to the maxilla. But this requires a pretty hefty investment, not something I recommend you do early on in your journey towards dental sleep medicine, which is why I wanted to talk about the phonetic bite. My office and I are currently employing a study where we're going to compare the results of the pharyngometer to the phonetic bite. My anecdotal perspective is that these two things end up more or less in the same area. I'm talking about where the mandible ends up in relation to the maxilla in three-dimensional space, not just horizontally or protrusively, but also vertically. So, in order to enter this world, I promised you that this would be inexpensive. The phonetic bite is just your tool for that. Because you're going to likely start taking more education in the world of dental sleep medicine, you're going to come across the George gauge. I wanted you to see what this is. You can order these from Great Lakes Orthodontics, and you will probably run into lots of dental sleep medicine docs that still use this. It helps. I do think this is better than not treating the patient, but I do think that there are better ways of asking the body where to put the mandible than simply forcing it forward. I think of this as the reverse centric relation. Centric relation, we're forcing the mandible into a place. Not here to say whether centric relation is right or wrong. We're all taught centric relation as a real thing, but I just want you to really kind of think about it. If we're asking the body through the phonetic bite, which we're going to talk about in a second, where the mandible wants to go through airflow, which produces speaking, I'm going to trust that position much better than I am having the patient force their mandible into a direction to gain some information on where the mandible should go. In the Miro board, I'm going to have a separate video on the phonetic bite. I've had a very hard time trying to learn this. There's lots of different literature out there. All of it I found incomplete. Over the past several months, I have a firm understanding of what to do now, and I'm going to hopefully do a video that dovetails with the step-by-step directions in the Word document or the Google Docs document in the Miro board. If you can't find the video, that's fine. Just locate the link on the Miro board that says phonetic bite. All right, so you've captured the three-dimensional position. You then are going to deliver the appliance. Yes, we could probably spend another hour or 2 or 8 hours on this particular concept. But what you're really trying to do is you're just asking the patient for comfort. You're teaching the patient how to take it in and out of their mouth, and you're assessing for Tmj stretch. Tmj stretch is unlikely going to be the case if you use the phonetic bite. The phonetic bite, you're most likely going to have the patient somewhere around edge to edge and 4 to 10 millimeters open from there. Somewhere in that arena is about where you're putting the mandible. Very few patients that don't have any TMD issues will have the stretch associated with that. You also want to educate the patient on bilateral imbalance. When they put this appliance in, if the appliance was made correctly, there's a high degree of likelihood that they're going to close down on one side and not the other. The mandible needs to find its balance point, and if you did the phonetic bite correctly, you're probably not going to have bilateral contact of the appliance right out of the gates. That's okay, because the appliance, when the patient starts biting down evenly, their muscles and their pharyngeal muscles are going to be in a much better place, which improves their airway. There's a lot to unravel with this concept. Just remember the following. If a patient's not biting down bilaterally at their first appointment, do not adjust it. That's actually what we want. If they do hit bilaterally, that's okay too. It might just be that they were balanced when you took the bite. Unlike a night guard, you need to follow up with these patients fairly regularly. I put titrations here. There are several appliances that allow you to do what's called titration. Titration is the act of adjusting the appliance to get a better clinical outcome. Titration is very much part of the technique taught by the use of the George gauge, and I would say probably 90 to 95% of all dental sleep medicine courses will talk about titration. One of the reasons we're such huge proponents of both the Pharyngometer and the Phonetic Byte, those are giving you the right answer. You don't have to guess after delivery and then adjust thereafter based upon the patient's assessment. The reality is when we speak or when there's air flowing through our airway, the muscles of the pharyngeal walls coordinate very closely to the muscles of mastication that control the mandible. They work in coordination with each other. So if you're having proper breathing and you're speaking, the muscles of mastication are going to position the mandible in a way that maximizes airflow. If we don't have airflow, we can't speak. So by use of the Phonetic Byte, we're actually getting a patient to understand, or helping the patient's central nervous system to understand where to put the mandible that maximizes airflow. Therefore, we have very few follow-up and titration appointments if we use the Phonetic Byte. If you've talked to any doctors in the world of dental sleep medicine, this is often the most frustrating part of the world. Titration after the fact, where you're seeing the patient multiple times, it's kind of like adjusting a denture. I don't know about you, but the reason why most dentists don't like dentures is the follow-up stuff, not necessarily the execution. If there's a method that we could get a denture to fit perfectly every time, do you think we would use that method? Absolutely. Well, the Phonetic Byte and the Pharyngometer get us there. If not, they get us very close to that point. So the follow-up and titrations, although relevant to the conversation, is something we try to avoid. Yes, we may adjust the plastic as needed. Again, I'm not going to go through all of these particular specifics. If you want to learn more about this, please feel free to reach out, and I have all kinds of documentation on how to go about doing this. Well, again, this isn't a night guard. We're not putting this in the patient's mouth to prevent something from happening. We're treating something. We don't have the ability necessarily to assess whether the treatment works or not. We do have some ability, but early in the game, what I recommend you do, after about 3 months of titration and fine-tuning, you send the patient back to the sleep physician for evaluation. They'll do another follow-up study if their insurance company covers it. Most of the time they don't, but let the sleep physician decide on what to do. Most of the time the patients are going to say, I sleep better, I'm less tired during the day, and the sleep physician will say, okay, it worked. There's really no scorecard necessarily in the subjective evaluation of a patient. If the patient can get the sleep study, then you can have an objective scorecard. And that's really what we try to do, and why I personally believe the home sleep study test is a valuable tool if you're going to start using this, treating these patients more aggressively or more commonly. Communication is not the topic of this conversation, but this is very valuable if and when you get into this world. Educate your team not to ask patients if they snore or sleep apnea or have sleep apnea. Encourage them to ask this: has anyone ever made a comment about your sleep quality? Patients aren't going to get defensive if you ask this question. If you ask them if they snore, you're going to get patients look at you from their side eye. Take it for what it's worth. I found this one particular approach to be very helpful in our practice. Well, what about some specific patients? Here we have Chuck B. He's a 65-year-old male that presented for a recall exam, just like all of our recall patients do. But he presented with severe scalloping of his tongue. Again, go to the Miro board, look at clinical signs and symptoms, and you'll see more about what that means. His medical history was consistent with type 2 diabetes, hypertension, and high cholesterol. This is the kind of patient that we think of when we think of sleep apnea. Hopefully, you understand that everybody can suffer from this, as we will see in a few case reports shortly. The hygienist asked him the question, as we talked about earlier, inquiring about his sleep quality. The hygienist says, "Chuck, has anyone ever made a comment about your sleep quality?" And Chuck says, "Yes, I have sleep apnea, but I hate my Cpap." This is going to happen to you. If you ask your patients this question enough, you're going to have a patient just like Chuck. The hygienist then said, "Would you be okay discussing some ways of helping your sleep apnea with Dr. Roy?" It's good to get permission from patients because at the end of the day, we're dentists. In their eyes, we have no business helping them with their CPAP machine or their sleep apnea. So the hygienist set the stage for me to come in and have that conversation. And Chuck complied. So then I said something akin to, this is years ago, so I don't remember exactly what I said, but for the purposes of articulation and illustration, "Chuck, we have a process that many patients, just like you is a very good tagline to use with your patients when you're trying to introduce a concept that might be offensive, that patients just like you have found extremely valuable. With the help of your primary care physician and or your sleep doc, we may be able to get treatment without a CPAP. Is a better quality of life something you're interested in?" Chuck says, "Sign me up as long as I don't have to involve that big machine." I do remember Chuck saying something similar to that. So then we send the letter that you can see in the Miro board to Chuck's sleep physician for a prescription for an oral appliance. We're asking the physician to be an active member in providing treatment for his patient, his or her patient, that is intolerant to the CPAP. This is the easiest low-hanging fruit in the world of dental sleep medicine. Again, you have patients in your practice that live like this. You're the only one that can help them at this point. You have two options. You can go to their house and force them to wear their CPAP, or you can help them with a mandibular advancement device. We then obtained the prescription from in Chuck's case, it was a sleep physician. He arrives for his oral appliance. We used a Phonetic Byte to obtain his three-dimensional position of the mandible in relation to the maxilla. We think of that as an occlusal record or a bite. We then sent the records to Diamond Orthodontic Lab for fabrication of an oral appliance. We deliver the appliance and follow up with Chuck at weeks 1, 4, and 24, and we see him for the purposes of his appliance every year thereafter, and we adjust as needed. We haven't needed to do any adjusting. Chuck didn't notice an improvement in his quality of life at week 1. It was really around week 4, maybe week 3, where he started to notice. Don't be surprised when your patients don't notice anything. That's why I'm a huge fan of the objective home sleep study test, because it provides a report card objectively of the patient's improvement in quality of life. Just because they're tired or not tired doesn't mean that they're not having lower blood pressure, lower risk for diabetes, hypertension, and all of the inflammatory conditions that really kind of strike Americans as we know today. In other words, patients don't necessarily notice things. So, huge fan of the home sleep study test as a way to help our patients realize that they have improved their quality of life through better health. So here are the specifics for Chuck's outcome. He had severe sleep apnea. His AHI, which is a measure of sleep apnea, we can think of this as how many millimeters deep a pocket is in periodontal disease. This is the 9 millimeter pocket. This guy had a 55. Yes, there's people that have 100 or above, but 55 is really bad. His sleep physician did test him with the Cpap. We had access to those records. His post-op AHI went down to a 17. Now, you may ask yourself, why is it not a 0? Well, that's because medicine is an imperfect science. We as dentists think everything has to be perfect. In reality, this guy's quality of life improved dramatically, except he didn't wear his Cpap. So he was still stuck at a 55. We then gave him an appliance and it went down to a 12. So not only did his Cpap not work because it wasn't in his mouth, for him, the oral appliance actually produced a better result. And there's all kinds of reasons why this could happen. This is not common. I'm not here to say oral appliance therapy is better than a Cpap. They're both tools, and in some patients, we actually use both of them. They are tools to help the patient. Here's a little diagram here. This is the continuum of advancing OSA disease severity based upon their AHI number. Again, AHI is an acronym for Apnea Hypopnea Index. It's essentially how many episodes per hour that they have problems with their breathing. You can think of it that way. Well, normal people, it might happen a few times per hour. 4 and under is considered normal. 5 to 15 is mild. Moderate, 16 to 30, and then severe, 30 plus. Again, you'll have patients in the hundreds. Those are the people that fall asleep at the stoplight when they're driving. We think that those are the people that have sleep apnea. Meanwhile, there's millions of people out there that live in the mild and moderate realm that might not necessarily fall asleep at the stoplight. They absolutely can be helped. And I can promise you that as a dentist that understands this stuff, you can be the one to help them. All right, how about another patient? Susie S. This is the atypical kind of person that has sleep disorder breathing. Interestingly enough, this patient is a female nurse that works at a sleep center. Now, you would think somebody with medical training that works at a sleep center wouldn't learn anything new from their dentist. Well, I'm here to tell you otherwise. Not only that, but she's an athletically built person. She works out all the time. She's probably 115 pounds soaking wet, and she exercises regularly. This is the antithesis of the guy we just saw before, who we think of the cheeseburger eating person who drinks alcohol every night, has diabetes, hypertension, what have you. Yeah, that person is the poster child for sleep apnea. They're just one of many kinds of people that can suffer from this condition. Again, she works at a sleep center with 3 sleep docs. She's been there for over 10 years. During her examination, she showed signs of sleep disorder breathing, presumably upper airway resistance syndrome. Again, the topic of today's conversation isn't so much about what UARS is and how to treat it. That's where our ENT colleagues come in, but we can screen for it. So we saw the signs and symptoms. We educated the patient. We tried not to be too abrasive from the fact that she's a nurse in a sleep center, and we encouraged the patient to get a sleep study, which then confirmed the diagnosis of UARS. The primary care physician, actually was a sleep physician, prescribed a mandibular advancement device, but also a referral to the ENT. Why is the ENT relevant here? Well, when we looked at that sagittal cartoon earlier, I told you that the UARS condition is a restriction in the upper airway or the nasal passage. So she needed both, and after she had both, she had a significant improvement in quality of life. She went from a 4 out of 10 to an 8 out of 10. All of this from a conversation started in a dental practice. But we're just dentists. It's amazing. Now, what's interesting with the patients that have UARS, their AHI is typically not abnormal. But we were able to improve her from an 8 to a 2. We took her from mild to normal, but her improvement in quality of life was substantial. As you start to learn in this world, the numbers are tools for us to understand, but they're not absolute. You can have a patient go from 100 down to a 10. They might not notice much. They're definitely living a better quality of life through better health, but they may not notice it as much as somebody that goes from an 8 to a 2, and vice versa. And there's all kinds of reasons for that. The point is, we help somebody live a better quality of life. Then the last person, and this is definitely somebody likely to show up at your doorsteps, is a younger male with no significant medical history. On his medical history form, he put that he snores, so we use that as an opportunity to learn more. He reported being the guy that everyone makes fun of when he snores. He goes on a camping trip with his buddies, and he's the one that everybody makes fun of. Well, it just happens to be, at 25 years old, he's an endomorph. He has an 18.5-inch neck. Your patients who have an 18-inch neck are at higher risk for obstructive sleep apnea. He's also a Mallampati class 4. This is essentially a classification tool that says how narrow the airway is or how obstructive it is. And he did report that he's tired during the day, especially after a night of drinking alcohol. Well, he wasn't necessarily saying he was hungover when he felt this way, just in general, when he drinks, he does feel worse. Well, that's not surprising. With that said, it gave us some clues that he might be suffering from obstructive sleep apnea. So we gave him the form, referred him to the primary care doc. He then had the sleep study. Diagnosis comes back with mild sleep apnea. His AHI is 13. Now remember, his AHI is 13 today. He's only 25 years old. I can almost guarantee that if we didn't intervene, this guy would have been 55 when he shows up at the doorsteps of the primary care doctor saying, I'm falling asleep at night when I sit down in my recliner and a commercial comes on and I fall asleep. Well, the damage has already been done. Unfortunately, the way the medical model is set up, these patients are not being seen at earlier stages of the severity. So don't think for a second that just because his AHI is 13, which is definitely considerable, is any less important than the person who's already at a 55 like we saw with the patient before. Well, guy's only 25. He's not interested in having a Cpap for obvious reasons. Well, his well-educated primary care doctor prescribes him an oral appliance, and that's where we come in. So we fabricated that. He also now knows, because he's aware that his AHI is 13, that he should modify his habits. Or he may soon require a Cpap or combination therapy. So it's very possible that in 10 years, when he's 35, that without any sort of significant lifestyle changes, he may indeed have to use a Cpap. In other words, he's now aware. Not only have we provided treatment for this guy, but we've provided awareness so that he can potentially prevent further issues from happening. He reports his quality of life improvement at 75%. Here are his statistics. Again, we took him from mild sleep apnea to no sleep apnea through the use of a mandibular advancement device. I don't know how many patients tell you after you do a class 2 composite that their quality of life has improved 75%. But this is pretty fulfilling stuff. It's life-changing not only for you, your team, the patients, but everybody involved, the spouses of the patients. As you can see, it's just substantial stuff. So what are the take-home message from the case studies? With the help of a dental office, that's you, these patients are now living an upgraded quality of life. There are a few things out there that you can do to have this kind of fulfillment living with inside of your professional cup. And the moral of the story, dentists absolutely play a critical role and necessary role in the screening, the diagnosis, and treatment of sleep disordered breathing. So you may ask, where do you start this journey? Well, today is hopefully an increased awareness, but you need to go somewhere in order to make this happen. The Miro board is there for you. The Miro board is a live document that I'll be updating as I start to increase the documentation and resources I have available to me and my team. I will include them there, so regularly take a look at it. But use the Miro board to start, and there's a link, I think, above the center that says how to start my DSM journey, or how do I get started in DSM, dental sleep medicine. Click on that, and there'll be some resources there for you to get started. Where are you going to get the patients? Well, your family and friends suffer from this disease. Ask them to see if you can help in some form or another. I guarantee there's people out there that fall under this criteria. Your staff, family, or friends. Probably the most common is the the husband of your staff members. They are often the last person to go to the medical doctor, so they're the person most likely to have undiagnosed conditions. If they like you, they'll probably let you dabble in this world. Okay, it's not uncommon that you'll get these patients to their primary care docs and they all of a sudden have a whole host of other conditions that now they're aware of. So if anything, it's a tool to get them to understand the quality of life is important through wellness. And then also altruistic dentistry or pro bono dentistry. Do some of this for free. Take the person who maybe doesn't have health insurance, doesn't have access to the safety nets out there in public health, and do these for free. Again, get the prescription from the primary care physician. But this is a great way to give back to society, but also learn at the same time. And then lastly, NECADE. NECADE is New England Center for Advanced Dental Education, which I'm the director of. My here is not to provide a plug for NECADE per se, but to show you that there are avenues out there where we talk about this stuff on a regular basis to hopefully provide you a framework or a safety net. If you're going to go into this world, you have somebody to lean on. NECADE is basically akin to an online mentor. If you have a mentor in your community, feel free to use them. But there's another way to do that, and that's through the NECADE Mastermind groups. There's several agencies out there that will help you. I've talked about a few of these here. I'm a huge fan of the American Academy of Dental Sleep Medicine. After you've done cases, get started. Don't try to, throw your money at these resources here as a way to hopefully learn about it. Lean on NECADE and allow us to help you get into this world. Once you've realized the value, then you can start employing these agencies. There's resources out there that kind of keep it front and center for you. The book Dental Sleep Medicine Basics by Dr. Mark Collins. You can purchase that on Amazon in addition to the books that we talked about before. This is more for you, not necessarily your patients. And then the periodical dental sleep practice that comes in the mail once a month. There's always good information in there, bringing you some awareness in the world of dental sleep medicine. So I talked about the NECADE DSM Mastermind. That's comprised of myself. Am I qualified to act in this capacity? I'll let you be the judge of that. But as a master in the Academy of General Dentistry, a qualified dentist in the Academy of Dental Sleep Medicine, completed the Mastery Series in the AA-DSM, and I'll soon be sitting for my diplomacy in the American Board of Dental Sleep Medicine. I do think I'm qualified to provide you some guidance in the early stages of your journey. I also have Dr. Elizabeth Walker. She's an orthodontist. How the heck does an orthodontist play a role here? The second you meet her, you're going to understand she's just passionate about improving quality of lives of everybody around her. She focuses her world in the world of dental sleep medicine and TMD, as we talked about. Sleep medicine and TMD are often one and the same. She has lots of advanced degrees. The second you talk to her, you're going to know that she knows what she's talking about. And then lastly, Raymond Champ, he's a hygienist that works with us, but more importantly, he taught dentists for several years through Sleep Group Solutions. He was an instructor. He went around the country teaching large audiences like yourself on the value of dental sleep medicine in the everyday clinical practice. And now he acts as our clinical director for this dental sleep medicine program at our Sauk River Dentistry practice. The three of us will be bringing in other characters to help guide you in that direction if you decide to lean on NECADE. NECADE.com is the website if you want to learn more about it. Just click on the Mastermind tab. Some dentist perspectives through their involvement with NECADE on dental sleep medicine. There are a few things in dentistry, Dr. M talked about, there are a few things in dentistry that fill the professional cup more than giving a patient an upgraded quality of life. You may have heard me use that term. It came from this doctor. I was very kind of struck by his way of using words to articulate how we impact people. And then Dr. R, although I love restorative dentistry, there's only so much I can affect restoring marginal ridges all day long. If I want to change the world, I've realized that dental sleep medicine must be part of my day. And I think that says it in and of itself. And then Dr. Y, thanks to NECADE and dental sleep medicine, I realized that I have moderate sleep apnea. If I was blind to the facts within my own body, then I must be a solution to help others come to that same realization. He's talking about in his patients, his friends, and his colleagues. And then he says, it's my ethical obligation. My story is very much the same. I suffer from moderate sleep apnea. My AHI pre-treatment was a 17. Through some weight loss and lifestyle changes, I got it down to a 12. Then I got it down to a 6 with my mandibular advancement device. Most importantly, my quality of life has never been better. So in conclusion, I do think that dental sleep medicine is something that can be part of your everyday practice. I encourage everybody to visit the NECADE website. Let's go there real quick, necade.com. We have several different mastermind groups, as you can see here. The goal is to have a platform where dentists can have a group of mentors to lean on when they get over their head. It'd be wonderful if we could refer everything. In reality, that's not the case. I implore everybody to understand that you have resources out there available to you with the internet, with your colleagues, your specialists. Don't try to do this alone. Well, thank you for your time, and I look forward to everybody accessing the Miro board. Here is the link, which will bring you to this. Anywhere where there's an underline, you can click on it, and there'll be a document waiting for your perusal. If you have any questions, feel free to email me. My email is dr_roy@SacoRiverDentistry.com. There's my email. All right, thank you again, and we'll talk to you all later.